Welcome. Good afternoon. We're excited to have another series of patient case discussions today. My name is Suresh Ramalingam. I'm a thoracic oncologist at Emory University's Winship Cancer Institute. And today I'm joined by a fantastic panel of multidisciplinary experts focused on thoracic oncology. And I'm going to allow them to introduce themselves. First, let me start with Dr. Michelle Ginsberg.
Hi, I'm Michelle Ginsberg. I'm Director of Cardiothoracic Imaging and Vice Chair for Education at Memorial Sloan Kettering Cancer Center, and also Professor of Radiology at Weill Cornell Medical College.
Hello, I'm Dr. Seth Force. I am the Kamal A. Mansour Professor of Surgery and Chief of General Thoracic Surgery at Emory University Hospital in Atlanta, Georgia.
Hi, thank you, and good day. My name is Dr. Wally Curran. I'm a radiation oncologist and the Global Chief Medical Officer of Genesis Care and Professor Emeritus at Emory University.
Hello, and good afternoon. I'm Tom Stinchcomb. I'm a thoracic oncologist at Duke Cancer Institute.
We're going to go over some very exciting cases. We have a wide array of cases today that represent important clinical considerations and contexts that we face in our clinic. This is a 61-year-old female who has about a 45-pack-year smoking history. Patient had stage 4 disease based on a right lung mass and a right adrenal metastases, along with additional sites of metastases. So let's get some additional information about the patient. This patient presented with pain in the chest wall, along with nausea. Her performance status was 1 on the ECOG scale. And we'll quickly review the imaging findings. The patient had a CT, chest, abdomen, and pelvis, and also had a brain MRI. I'll just pull up the images and invite Dr. Ginsberg to talk to us about the findings on the scans.
We see that there's a large right upper lobe mass at the right apex, and in the left lung, we see a subpleural nodule laterally. In addition, there's a supraclavicular lymph node that's enlarged and a large right adrenal mass. The adrenal mass at the bottom right is this large lobular mass. And we're also told that our abdominal nodules consistent with peritoneal metastases, but not demonstrated on these images. And the brain MRI was negative for any metastatic disease. And additionally, there's paratracheal adenopathy on the CT scan. We don't have the soft tissue windows, but we could see through the lung windows that there is large paratracheal lymphadenopathy.
So the patient underwent a CT-guided biopsy of the right adrenal mass. The pathology revealed the diagnosis of poorly differentiated carcinoma, favoring large cell carcinoma or pleomorphic giant cell carcinoma. And you can see the immunostains positive for Vimentin and CAM2, TTF1, NAPSIN-A, P40 were all negative. The PD-L1 expression was greater than 1%, though we don't have specific information on how much exactly it is. So this patient, Dr. Curran, is presented with severe pain, extensive metastatic disease. I take it that we're not thinking of surgery given the extent of disease. So palliation is clearly in the front and center of our mind. Can you talk to us about providing pain relief and palliation to this patient?
Yeah, adrenal metastases, as you know, Dr. Ramalingam, when they're that bulky, can be very painful. It's really stretching the nerves of the capsule as well as potentially compressing adjacent structures. So very, very painful. Radiation is effective if a dose is given and planned well. For a lesion of that size, I think the ideal way to give radiation would be to CT-based planning with intensity modulated radiation. It's also good to have a technology plan to deal with motion, because with a patient with that much pain and perhaps lots of diaphragmatic movement, that large lesion could move around a lot. So having onboard high quality imaging in the room with what's known as cone beam CT or even MR capacity would be helpful. But 20 gray and 5 fractions given with a advanced technology could be quite helpful for this patient.
Thank you, Dr. Curran. How important is the size of the adrenal metastases and the type of radiation approach utilized? Because sometimes we would have patients on targeted therapy who have oligoprogression in the adrenal gland as a solitary site of progression, and we would refer the patient to you and talk about how this situation may be either same or different from the other scenario.
Yeah, I think the goal should be the smallest number of fractions that get the job done in terms of pain relief without putting the patient at too high risk for acute effects. I think in most cases, 3 to 5 fractions should be the right number. If it's a smaller lesion, it can probably be done in 3 fractions. And 10 gray times 3 would probably be a reasonable fractionation regimen for an adrenal lesion.
Thank you. So Dr. Stinchcomb, obviously the big question is what's the appropriate systemic therapy for this patient as we think about the next steps. So talk to us about how you would approach this situation, large cell neuroendocrine histology, or a question about pleomorphic giant cell carcinoma.
For the large cell neuroendocrine, I tend to group these with the small cells, sort of a high-grade neuroendocrine. I've historically treated them with a platinum etoposide and now with platinum etoposide plus immunotherapy. I have to admit that that's just my practice pattern. Some people have elected to go through treat them like non-small cell lung cancer. But in this situation, I would probably, if the patient's a good candidate, do platinum etoposide plus immunotherapy as the next step.
What would be the role of molecular testing in this patient? Would you recommend an NGS testing? We know that this patient's PD-L1 expression is positive, but what about beyond that?
I thank you for bringing that point up. That's a good point. I often will also do that just because there's so many limited options and there seems to be some ambiguity about the histology. But I think we really need to move from a field that's testing all lung cancer patients with an NGS panel. All non-small cell lung cancers with an NGS panel, just to make sure that we're not missing a potential actionable mutation or one of those rare occurrences that we could enroll a patient on a clinical trial.
So in this situation, what would be the role of immune checkpoint inhibition? Is this something you would give with chemotherapy, or would you just treat this patient with chemotherapy?
I would do a chemotherapy and immunotherapy combination at this point. I think the PD-L1 we know it's greater than 1%. We don't know if it's greater than 50%, but I think there were not a lot of large cell neuroendocrine tumors enrolled in those trials. And I've extrapolated from the small cell experience where single agent immunotherapy is not very active, but the combination of chemotherapy and PD-1 inhibition works very well.
We also know that the combination of EP and nivolumab is also approved in non-small cell lung cancer in the frontline setting for PD-L1 greater than 1% patient population. Where does that fit in your treatment algorithm? Is that a consideration for this patient?
That would be a consideration. Personally, I've not used the nivo-ipi combination frequently. It is an option I discuss with patients. But I think I'm not sure that offers greater efficacy. I think that there is a concern about slightly more immune-related toxicities. And so I think in this patient who's a large cell neuroendocrine, I think I want to do a chemotherapy plus a PD-1 inhibitor, but if a referring physician had done a nivo-ipi, I think that is also a reasonable choice.
And the point you made about should we treat this as a small cell or a non-small cell is an eternal question. I remember the old study by Dr. Scagliotti that compared cis pemetrexed to cis gemcitabine long time ago, showed that in neuroendocrine histology, the cis pemetrexed regimen did quite well. So would a pemetrexed-based regimen be an alternative in this situation?
I apologize. I thought the patient had received that already. Am I incorrect?
Yes, this patient just started carboplatin pemetrexed.
No, and so that was driving a lot of my thinking. But
okay,
the platinum pemetrexed, as you articulated, was a reasonable option in non-small cell lung cancer. In this case, though, when the patient had progressed on that, I felt it was behaving more like a high-grade neuroendocrine and would switch to maybe a small cell-based treatment paradigm.
Yeah, I think this patient ended up starting the carboplatin pemetrexed and then subsequently, unfortunately, had disease progression. And at that point, obviously, we would have to consider a salvage therapy approach. And that's where your approach of small cell lung cancer type of treatment is what you were recommending. Now, when you're talking about small cell, we have now two different immunotherapy approaches approved. One is the chemotherapy plus atezolizumab. The other is chemotherapy plus durvalumab. And they both seem to have comparable efficacy, even though they were not compared head-to-head in phase 3 trials. What is the duration of immunotherapy in these situations? How long do you continue on with immunotherapy?
I continue until disease progression or unacceptable toxicity. And so that those patients will get 4 cycles of the chemoimmunotherapy, then convert to a single agent immunotherapy with routine scans at that point. And so I do use the maintenance immunotherapy approach as used in the trials.
Dr. Karan, in these situations, after patients have had a few cycles of chemotherapy, if you have a good response, in this case, this patient ended up with left supraclavicular node and some pleural progression. Would you consider revisiting radiation in this situation?
Yeah, I think it's good to revisit it. I remain skeptical on consolidative treatment for metastatic disease in either small cell or neuroendocrine tumors. It can be useful palliation, but I'm a bit skeptical as to its long-term benefit, and really aren't a lot of great studies to support it, in my view.
Thank you. So this patient, the overall recommendation is in a situation where you have large cell neuroendocrine carcinoma that has been palliated with radiation to the adrenal and progression with first-line chemo using an immunotherapy chemo combination approach is the recommendation of this panel.